Great. Thank you for the kind introduction, and thank you to the organizers for the invitation. Today I'll be talking about toxicity in new and established HBV compounds. So here are my disclosures. So first I'm going to go through briefly toxicity of established therapy, and then I'll spend most of the time talking about toxicity of new compounds, what I've divided into sort of expected and what you might describe as unexpected toxicity, and then briefly talk about different populations where this might be relevant. So let's talk briefly about established therapy. And I think with nukes, we know that they have overall excellent long-term safety. Early on in Tekavir, there were concerns raised about lactic acidosis in patients with advanced or decompensated cirrhosis, and this doesn't seem to be a big problem. It's likely a small concern with any nuke due to potential for mitochondrial toxicity, which is greater in a very sick liver. And of course, we learned too much about this with the old FIAU story very early in nuke development, but clearly this is a pretty rare phenomenon and really only applies to those patients with very advanced liver disease. When we look at the tenofovir therapies with TDF, the big issue is renal tubular toxicity and related phosphate wasting bone toxicity. And we know that these are certainly occur, but at the population level are pretty rare. They're more of an issue for individual patients, and really with good patient selection, they're less of a concern, but those with higher risk factors, older age, diabetes, hypertension, underlying renal disease, and longer duration of exposure are at higher risk. And if we move to TAF, we know from both the comparative studies and then the switch studies that you can reduce that toxicity profile due to the lower exposures. So we still need long-term safety here, but I think this looks quite promising. Now, what about interferon? Well, we all know the many side effects that interferon can cause, but I think it's important to recognize that most of these are actually not treatment limiting. Most patients get through the planned duration of therapy. And of course, some data to suggest that interferon-based therapy might be better tolerated in Hep B than in Hep C. Whether that's really true is hard to say, but I think it's important to recognize that shorter therapy with interferon might be possible. So, and I think the number of 3 months is often thrown around as where it might be acceptable to get patients through a shorter course as part of combination therapy. Probably the bigger challenge will be convincing providers to use interferon than getting patients to take it. So what about toxicity of new compounds? And I'm going to talk here about expected toxicity. We know we're going to see some ALT flares. Some of them are good. So that's predictable. Immune-related toxicity is potentially a predictable concern. And then there might be some that are specific to compounds or specific classes of therapy. And then the more challenging one is unexpected toxicity, the idiosyncratic reactions. Now, Pietro just talked about ALT flares, so I'm only going to go through these briefly, but I think it's obviously relevant to talk about this with toxicity. So we generally think about these as therapeutic flares, the sort of good flares, and then the less good flares, drug-induced liver injury or immune-mediated hepatitis. And the therapeutic flares, we usually think about these being associated with viral control, suppression of virus if they're not on nukes. It might lead to E antigen loss, and I think the association with E antigen loss is much clearer with the flares. Clearly with S loss, it can happen, but we actually often see patients just petering out and losing S without a flare over time. Now, these flares should be by definition self-limited, but it's important to recognize that they can be severe and occasionally even fatal. Now, of course, losing S, if you lose the patient, not really a good outcome. So these are good, and they're what we want to see as long as they're not too severe. The other consideration with these good flares is that they can occur after stopping an effective drug, and sometimes even the stopping may lead to our therapeutic flare, but these again can also be a bit dangerous, although nuke rescue therapy might be helpful. The drug-induced liver injury, typically idiosyncratic, but they may be dose dependent. Usually the mechanisms aren't known, and the challenging thing here is that using our usual tools for interpreting these, like Hy's law, may be challenging with elevated ALT at baseline, but they can be severe or fatal, and aside from transplant, we don't usually have good therapeutic options. And immune-mediated hepatitis, these are really probably restricted to the checkpoint inhibitors, although other immunotherapies might do the same thing. They're usually rapid onset. They can be severe or even fatal. Fortunately, they typically are steroid responsive, but not always. And I think we need more data here to understand them better. Clearly, biomarkers to distinguish these are currently limited, but they're desperately needed. Liver biopsy might help in some occasions. So I'm going to go through a couple of examples where we look at these ALT flares and we try to make sort of guesses about what's going on. And I think a lot of excitement about the NAPs in terms of the S declines, really potent S declines with these agents. but with significant ALT rises. And what we're hoping these mean is that this is immune restoration that's leading to these ALT flares and subsequent immune control. And I think really, so hopefully that's what we're seeing, but I really do think we need to prove that with good immunological studies, both in the blood and ideally in the liver as well. And I'll talk about some tools for doing that. And I would highlight that this isn't unique to NAPS. We see this here with the GSK antisense, where you see these pretty significant S declines, importantly with very frequent dosing over a 4-week period. And what you see here is that in both nuke suppressed and naive patients, S decline, and then a very quickly following with an ALT rise. And if you look at this and you correlate them, you see that the peak ALT is associated with the greatest declines in S. So what's the mechanism here? Again, we'd like to believe that this is immune restoration, and that this is not toxicity or something else entirely, but I think we need more data here. So here, what can we use to try to tease this apart? Well, Conan Chua, a PhD student in Adam Gehring's lab in our group in Toronto, has developed what I think is a nice tool for helping to tease this apart. So what he's looked at is, can you actually identify immune responses in pretty much real time? And what he's done here is you take PBMCs and you look for pooled immune responses. So this isn't telling you that someone's having a response to S or to core or to POL, but it is telling you whether or not they're having an increase in their HBV specific global immune responses in their peripheral blood. It can be done in pretty much real time. Now, we first looked at using a standard interferon gamma ELISpot, and he could see responses, but when he went to a 3-color fluorospot, which has a couple of advantages, first of all, in vaccinated donors and in chronic Hep B patients, he saw he could more frequently identify responses. But the other advantage is he could see polyfunctionality here by looking at interferon gamma, IL-2, and TNF alpha. This allowed him to determine something about the quality of the response, just not only its presence or absence. So this might be a nice tool to help evaluate whether a flare is really an HBV flare or a toxic flare. And I'll give you an example in a moment where this might be useful. Alternatively, we can actually look in the liver, and there's been accumulating data of using fine needle aspiration liver biopsy to do this. Some nice work out of Malamaini's group, and our group in Toronto has also done a lot of work with this approach. And it's important to recognize that you really can distinguish the liver immune signature from the blood. They really do look distinct, and you get reliable sampling of the intrahepatic immune compartment, and it's been compared with Mala's group to liver biopsy, showing similar responses. Importantly, some limitations to consider here: the cell numbers not huge, about 50,000 cells, and they're mostly immune cells. So this is good for looking at immune responses, but you get a pretty limited number of hepatocytes, only about 10%, and they're of variable quality. You cannot look at histology here. This is pretty well tolerated. So you can do serial biopsies, serial FNABs, which is nice. Useful to have a baseline though here. And this would be nice for looking at evaluating flares and better understand them, and maybe toxicity, but this is probably better for evaluating flares. So here's an example where this might have looked like these were good flares. So this is with this pretty potent CAM that looked like it was working pretty well. And you could see that some patients had good virologic responses, but also had ALT rises. And the first feeling is, oh, these are what we want to see. S is going down and we're seeing these ALT flares. But then when this was followed up by studies in healthy subjects, you see that these ALT flares occurred. It seemed to be restricted to Asian patients that had at least 2 weeks of dosing. But interestingly, this looked like it was also an immune activation flare. So you could see this IP10 interferon gamma rises in concert with the ALT increases. So you could easily see how someone could interpret these as being a beneficial sort of immune active type response, and not thinking of these as toxicity. And that would be a concern. So it's important to recognize that you really do need to dig deep. You can't assume that these flares are good. And using some of those tools I just mentioned might be helpful. Of course, we don't know if this is unique to this agent. So far, we haven't seen it with other CAMs, but clearly we need to keep a close eye. Now, this, I think, is a useful reference from the HBV forum, where they've put together some guidance about how to evaluate safety in new clinical trials for new agents. And I think it is quite a useful tool, the type of workup you might want to do and things to think about in evaluating toxicity. Now, what about immune-related toxicity? Well, this has been mostly studied in the checkpoint inhibitor world with PD-1, PD-L1, and CTLA-4. We know that in cancer, certainly this is sort of accepted toxicity, but we know that you do see these immune-related adverse events in almost any compartment, so almost any organ, and some of these can be very serious and even life-threatening. Um, and people have thought about using reduced doses for something like in well-controlled Hep B, where the need is less clear. But it's important to remember that the risks are likely more related to receptor occupancy than dose. So I think we really need more data on what is the frequency of these when you use lower doses. And I think one of the things we should really look to the cancer world from, because there's a vast experience here, can we select our patients more effectively to reduce the risk of these? Is there ability to do on-treatment monitoring to help find that sweet spot? Because this could be an attractive tool, but we really need to be careful because the toxicity can be quite drastic. And I think it's a question of, can this occur with other immunomodulatory therapies? We don't really know. So how do we know? Well, we'd like to be able to predict this. Unfortunately, like with most things, as with this election, we're not so good at looking forward in time. In hindsight, we can look back and say, oh, we should have seen that coming, but not always so easy to predict the future. And this was best exemplified by this example, where inirigavir looked like a potent HBV drug and looked like a novel approach. It looked promising until it didn't. With ALT elevations were seen with increasing dose duration, 40% at week 8, almost 90% by week 16 of dosing. And then you see this one patient with severe pancreatitis, lactic acidosis, liver failure, 7 patients admitted, 1 died. And importantly, some of these patients did actually have responses. So again, you've got to be careful to not get too excited by a response and say that toxicity can't also be occurring. Toxicity seemed to be duration related, but it wasn't obvious until it was obvious. So this is, again, challenging about trying to predict the future here. And mild ALT elevations were initially thought to be a good thing. So really understanding the mechanism here will be important to guide future therapies. What about compound or class specific toxicity? And I think with the antisense approach of siRNA or antisense, it's really important to think about off-target mismatches. And the FDA has given some guidance here that you've got to look in both the human and mitochondrial transcriptome to look for possible matches and then monitor toxicity specifically where those matches might occur. And then also think about polymorphisms that might be different by race or ethnicity. And then I think it's important when you're thinking about longer term therapy about whether the frequency or duration of these therapies will affect normal microRNA processing or RNase H function within the cell. And there are approved agents in these classes, so hopefully that's not an issue, but I think we need to keep an open mind. And then you need to think about host targets, and probably the best example here is Mercludex-B, where it also inhibits bile acid uptake. And of course, short-term inhibition seems to not be a problem, but what about if you have to give this as long-term chronic therapy? Does that become a bigger issue? So unexpected toxicity, of course, by its nature, it's unexpected. It's hard to predict hepatic or other idiosyncratic reactions elsewhere. We are getting better at model systems for predicting this in the liver, but they're still not great. And I think this does sort of make a case for shortening duration of therapy, as was seen with inirigavir, that these can be dose or duration related. And this was also exemplified by the BMS HCV polymerase inhibitor, where with longer dosing wasn't seen in short-term dosing, and it really does make the case for long-term animal toxicity studies to make sure you don't see these effects and they're more predictable. The FDA does recommend storing DNA to see if you can see genetic associations if these occur. Predicting off-targets effect, this was an old study that was published in Nature, which was really looking to identify ways to repurpose drugs. So you knew you had a mechanism. Could you think about how you might be able to repurpose a drug? But it can also be useful for identifying possible toxicity, where if you find toxicity, you might be able to say, how is this? What's the mechanism here? Can I tweak a drug that had a promising look to it to take away that toxicity risk, but keep the active antiviral effect? So I think using this approach, and this was a primarily bioinformatic approach, but has been useful for streamlining promising drugs. And then about the population, cirrhosis is a group where clearly the greatest need, but also the biggest risk, and they'll probably be studied last, and it may not be appropriate for certain types of therapy at all, particularly the immunotherapies where tipping patients over into liver failure might be a risk. Same thing might be said for the elderly, where clearly we need to treat these patients, but immunotherapy might be a challenge, both in terms of response and toxicity. And I think with the pediatric group, we'll probably do what we usually do is look for safety in adults first, except for maybe pediatric targeted therapies like in the IT population. Pregnancy, probably less of a focus for HBV cure because of our existing safety with nukes and vaccine. So to summarize, current therapies with fewer no AEs and very limited long-term toxicity raise the bar for new therapies. And safety probably needs to be comparable to nukes with short-term AEs may be acceptable if they have, but and with for high surface antigen loss, but true toxicity not so much. And careful evaluation of toxicity is clearly critical. ALT evaluations will be the most challenging. I highlighted a few new tools, the fluorospot and FNAB. Keeping an open mind for other toxicity will be key, and really trying to understand the mechanism will be important. And I think limiting duration would be a wise approach as much as possible. And with that, I'll thank you for your attention.